inhibitors because they inhibit the prostaglandin stimulation of collecting duct potassium secretion, and they inhibit the renin release. They result in hyperkalemia. Digoxin, because it inhibits the sodium potassium ATPase, is not able to return the potassium back into the cells and therefore can result in hyperkalemia. Calcineurin inhibitors, often used nowadays in transplant patients and patients with nephrotic syndrome, they are also inhibit the sodium potassium ATPase and can result in hyperkalemia. So the renin-angiotensin aldosterone system is a very important mechanism. Disturbance of this system is a very important mechanism for hyperkalemia. And this could happen at any of the levels as we have just discussed. So there could be angiotensin converting enzyme inhibitors, angiotensin receptor blockers, impaired aldosterone mechanisms because of heparin or adrenal disease, aldosterone receptor blockers like heparin, like spironolactone, sodium channel blockers like amiloride, and impaired release of renin by NSAIDs or beta blockers or cyclosporin. They can all result in dangerous levels of hyperkalemia. A word about pseudohypoaldosteronism and congenital adrenal hyperplasia. These conditions result in hyponatremia along with hyperkalemia and metabolic acidosis. So if you see in PHA1 or pseudohypoaldosteronism type 1, there is loss of function mutation of the ENaC channels. And therefore, sodium is not absorbed. And therefore, the effect of the mineralocorticoid receptor is missing also on the ROMK channel because less of sodium is absorbed. Therefore, less of potassium is excreted out. And therefore, there is hyperkalemia. The same could happen in an autosomal dominant inherited PHA1, where there is loss in function mutation of the mineralocorticoid receptor. You could have a salt wasting type of congenital adrenal hyperplasia, where you have a deficiency of 21-hydroxylase enzyme. In this, you will have deficiency of aldosterone and glucocorticoid. And we know that cortisol as well as aldosterone, they both stimulate the mineralocorticoid receptor. 11-beta-hydroxysteroid dehydrogenase type 2 helps in the conversion of cortisol to cortisone. Cortisone has little mineralocorticoid receptor action. Therefore, you could have in patients with apparent mineralocorticoid excess, also you could have excess of cortisol and therefore excess of mineralocorticoid effects. Patients with congenital isolated hypoaldosteronism are also there who have hereditary defect in the aldosterone synthesis that results in hyperkalemia. PHA2 or Gordon syndrome results in excessive absorption of sodium chloride through the sodium chloride cotransporter, which blunts the effect of the ENaC channels and therefore the effect of the mineralocorticoid receptor, and therefore hyperkalemia develops in this situation. So this table summarizes some of the common conditions associated with pseudohypoaldosteronism. So in an autosomal dominant PHA1, you have varying severity of asymptomatic to failure to thrive or chronic dehydration. But these patients have elevated renin and aldosterone that may normalize with age. So they may require salt supplementation from ages 1 to 3 years or even less. They have mild hyponatremia, hyperkalemia, and metabolic acidosis. Unlike patients with autosomal recessive variety of PHA1, where there is defective ENaC sodium transporter, loss of function of ENaC sodium transporter, there you would have more clear hyponatremia, hyperkalemia, and metabolic acidosis. They have elevated levels of renin and aldosterone and would require lifelong supplementation with potassium binding resins and salt supplementation. PHA2 or Gordon syndrome is also associated with hypertension because of increased sodium retention through the sodium chloride cotransporters. So they have hyperkalemia, hypertension, and hyperchloremia along with metabolic acidosis. So this is a monogenic cause of hypertension. The hormone levels are renin and are normal and aldosterone are normal in this situation. These patients have low thiazide diuretics. Their treatment requires low dose thiazide diuretics. In fact, these patients are very sensitive to thiazides. With 21-hydroxylase, the salt wasting variety, you may have ambiguous genitalia in females, or you may have hyperpigmented genitalia in case of males because of increased amounts of ACTH. These patients have hyponatremia, hyperkalemia, and metabolic acidosis. They have decreased levels of cortisol and aldosterone. They require corticosteroid and mineralocorticoid supplementation. It is inherited as an autosomal recessive disorder. Hyperkalemia, therefore, can have varied spectrum of clinical manifestations ranging from symptomatic to asymptomatic. The asymptomatic patients usually have mild levels to moderate values of serum potassium. They may have ECG changes, but they are often detected as a part of evaluation of a renal disease or a patient with cell injury or decreased effective arterial blood volume. Those with symptoms generally have values above 7 milliequivalents per liter. They often have ECG changes and conduction abnormalities of the heart. They may also have muscle weakness and paralysis. The cardiac conduction abnormalities are seen with increasing values of serum potassium. So with values of 5.5 to 6.5, you may just get tall peak T waves with short QT intervals. But as the values rise to 6.5 to 8, you have additionally prolonged PR intervals, decrease or disappearing P waves, and widening of the QRS complexes. With higher values, you might find absence of the P waves and bundle branch block, and occasionally you might encounter a sine wave or ventricular fibrillation in such patients. So the evaluation of the management, in fact, of hyperkalemia is always takes a precedence over its evaluation. The urgency and the type of interventions are usually based on the degree of potassium elevations, the presence or absence of symptoms, and the ECG findings. So how do we go about investigating a patient who presents with hyperkalemia? There could be some historical clues that help us in establishing the diagnosis. For example, patients on chemotherapy with a large tumor load, they may have tumor lysis syndrome. Patients who have unusually large intakes of potassium as IV fluids or as medication or as massive transfusions may have high hyperkalemia because of that reason. Sometimes you may have a patient with known renal disease with a decreased urine output, and therefore the cause is obvious there. At times, you may have history suggestive of potassium leak in the form of significant hemolysis or a massive trauma or an excessive exercise, muscle cramps, or rhabdomyolysis, giving rise to hyperkalemia. The physical findings also could give a clue as to the underlying cause. Hypertension and edema are indicative of a renal disorder. A decreased peripheral pulses and low blood pressures or tachycardia or evidence of delayed capillary refill are indicative of a reduced effective arterial blood volume. Patients having muscle tenderness may be cases of rhabdomyolysis. So further lab testing may be needed for patients with hyperkalemia, especially testing for renal function, because CKD is one of the important causes for hyperkalemia. You must look at urine analysis to look for proteinuria and hematuria. Sediments may indicate an underlying renal disorder. Look at platelets and the LDH values to establish hemolysis in patients with HUS or blood dyscrasias. Look at serum creatinine and urine for myoglobin for evidence of rhabdomyolysis. Looking at other electrolytes and ABG or other abnormalities, particularly metabolic acidosis. If you suspect an endocrinopathy, you may go in for hormonal assessment. Blood glucose for patients with diabetes, for example. Urine potassium is important to detect whether there is the normal potassium excretion is happening at the renal level or not. Urine sodium should also be assessed to look for whether there is a decreased effective arterial blood volume. A transtubular potassium gradient measures the net potassium secretion after correcting for urine osmolarity. It chiefly differentiates the hyperkalemia arising because of aldosterone deficiency or resistance versus non-renal causes. So normally in the presence of hyperkalemia, the urinary potassium, if the kidney functions are normal, they should be high. So a value TTKG more than 10 suggests usually a normal aldosterone response or an extra renal cause for hyperkalemia, and a low value below 5 would generally suggest aldosterone deficiency or resistance. Also, a response to mineralocorticoids like fludrocortisone establishes that if you get this value above 10, that indicates that there was deficiency of the hormone or hypoaldosteronism was present in the patient. On the other hand, if there is no change, there is some receptor problem. So how do we approach hyperkalemia? So if you have a patient of hyperkalemia, the first thing one must do is try to rule out pseudohyperkalemia. Look at the technique of drawing blood, squeezing blood, particularly in young children, and drawing blood through needles, which often happens in very young children, could result in pseudohyperkalemia. Also, this standing sample may lies and can result in fictitious high values. Patients with thrombocytosis and leukocytosis could also result in hyperkalemic values. So if you find high, look at the, if you have ruled out pseudohyperkalemia, and then you look at the daily potassium excretion. If you find that the excretion is high, potassium excretion is there, then you look at extraneous potassium input. Is this high output because of high input, medications, transfusions, etc.? If not, is it because of high endogenous potassium input, like cell lysis, hyperosmolarity, some depolarizing agents, cyclosporin, etc.? On the other hand, if you find that the potassium excretion is low, you check whether the urine output is adequate. If the urine output is adequate, you check for the aldosterone level. If you have high aldosterone levels, then this is the case of pseudohypoaldosteronism, type 1 or type 2, or is under the effect of potassium-sparing diuretics. On the other hand, if you have low aldosterone levels, this is the case of hypoaldosterone. So this could be because of a case of adrenal insufficiency, or it could be because of type 4 renal tubular acidosis. Also, if you find that the adequate urine, if you check for adequate urine output and you find that it is not there, that means there is decreased tubular flow. This patient may be a case of AKI or CKD, or there may be some kind of hemodynamic instability resulting from sepsis or heart failure. So before we treatment, we need to confirm that the values are correct. We may look at the ECG changes to confirm that. We rule out the evidence of hemolysis on the lab specimen. If required, we recheck the blood, and then we begin the management in these patients. So the first thing is to stabilize the myocardial membrane, and this is under the effect of calcium. 10% calcium gluconate at 0.5 ml per kg antagonizes the cellular effects of hyperkalemia and stabilizes the cardiac membrane without actually changing the potassium levels in the serum. Next, the effect to drive the extracellular potassium back into the cells, you might use beta-2 agonists as inhaled salbutamol, or you might use insulin glucose solution. This drives the potassium back into the cells by increasing the sodium potassium ATPase in the skeletal muscles. Soda bicarb also causes alkalosis, leading to potassium wasting. The removal of potassium from the body can be done by using either loop diuretics or by using resins, exchange resins. Hemodialysis, of course, is very effective for very high values, and patients with deranged kidney functions, hemodialysis would be the better way to lower the serum potassium. Now, the pharmacological therapeutic approaches would have different use in different situations based also on the time of onset of their action. So while calcium would have an effect within 1 to 2 minutes and stabilize the myocardial membrane, it should be used in patients who have very high values, say above 7, or showing ECG evidences of hyperkalemia. On the other hand, potassium exchange resins, they take very long to eliminate the potassium. So they are not very good options in acute conditions. Beta-2 mimetics and insulin glucose could help to drive the potassium into the cells within 15 to 30 minutes. And loop diuretics can also help in potassium elimination. If the kidney functions are normal, then loop diuretics could be used. So for mild hyperkalemia, you can just stop the potassium intake first and maybe administer potassium-sparing diuretics, provided the renal functions are normal. For moderate values, ranging between 6 to 8, one might use sodium bicarb infusions or glucose insulin infusion. And be careful to note that patient is not hypervolemic in the presence of sodium bicarb infusions. With severe hyperkalemia more than 8, one might resort to using IV calcium gluconate immediately and nebulize salbutamol to drive the potassium back into the cell, and then use other modalities. For refractory conditions with renal failure, dialysis, of course, is the option. So for management of acute pediatric hyperkalemia, we first check whether the patient has any ECG changes, muscle weakness, or potassium values exceeding 7, or serum or plasma potassium ranging between 6 to 7 with some ongoing risk of a potential rise in this. If that is the case, then emergent therapy has to begin. If you have an IV access, you may use IV glucose infusion along with IV insulin and glucose and IV calcium. If you don't have one, then you may start with inhaled beta adrenergic agent and try to obtain an IV access. Always remember to have serial lab assessment of potassium to modify your therapy, and you may have a continuous ECG monitoring for the same purpose. For patients who respond to initial management, when the serum plasma potassium falls below 7, the clinical findings have improved, the ECG changes have reversed, there are no ongoing reasons for increase of potassium. If that is the case, one might resort to the non-emergent therapies, which includes correction of the reversible causes of hyperkalemia and helping to remove the excess potassium by using resins, diuretics, etc. In case if that doesn't happen, then you may have to repeat the emergent therapy. This is the 11-day-old male child, third issue of consanguineous parents with a birth weight of 3,500 grams, breastfed from day 1. He was noted to be dull, lethargic, and irritable, poor feeding from day 7 of life. On admission, he was dehydrated, hypotonic, and tachypnic with a respiratory rate of 66 per minute. He was a normal male. He had normal male genitalia, but there was excessive scrotal hyperpigmentation. His weight at admission was 2,800 grams, and his calculated weight loss was around 12.5%. His septic screening was normal. Blood sugar random was normal. Serum sodium was low, so he has hyponatremia with hyperkalemia. He had serum creatinine of 0.75, a urea of 50. ECG was showing tall T waves. A provisional diagnosis based on these findings was of CAH. We began treatment by giving fluids, calcium gluconate, salbutamol nebulization, insulin glucose. Subsequently, we measured his 17-hydroxy progesterone level, which was more than 50 nanogram per ml. This was highly suggestive of congenital adrenal hyperplasia. His aldosterone level was normal, and the cortisol level was low. The plasma renin was high, and the serum testosterone and ACTH was also high. This confirmed the diagnosis of salt wasting variety of congenital adrenal hyperplasia. The urinary sodium wasting was present. Around 67 milliequivalents per liter was the urine sodium. The patient was started on replacement therapy with hydrocortisone and fluorocortisone, and within 5 days, there was significant improvement both in his clinical and condition and the biochemical parameters. On discharge, his weight was 3.7 kilograms. The steroids were gradually tapered over the next 1 week, and he was discharged on maintenance doses of oral steroids, both hydrocortisone and fluorocortisone. So the key messages from this talk is that potassium, body potassium, only 2% resides in the extracellular compartment, but it's important for vital functions of the body, and therefore its tight regulation is vital. Serum potassium, remember, is a poor indicator of the total body potassium. Renal secretion is the main way that potassium is regulated, and that balances the ingestion and excretion. The uptake and release by tissue cells prevents the large swings in the serum potassium. Serum potassium disturbances usually result from the disturbances in the ICF to the ECF shifts, or because of altered renal losses. And it's vital to return the serum potassium to normal levels in an emergent fashion in order for it to be life-saving. Thank you.
Yeah. Thank you, sir, for this comprehensive talk on the potassium homeostasis. Now, I think we have questions. Can we take some questions, Dr. Kalemia, and then?
Yeah, sure, sir.
Yeah, okay. So first question is for Dr. Kiran. So one of the attendant asked Dr. Manju, why hypomagnesemia is seen more common in Gitelman as compared to that of the Bartter syndrome? Dr. Kiran?
Yes. Yeah. So it's an interesting observation that for some reason the difference between Bartter and Gitelman is the hypercalciuria and the hypomagnesemia. So as we saw in the flow chart that the mechanism of calcium magnesium absorption in the thick ascending limb of loop of Henle and the DCT is somewhat similar but slightly different. In thick ascending limb of loop of Henle, the magnesium absorption and the calcium absorption is more of a passive absorption, that is a paracellular route, whereas in the thick descent DCT, which is the NCC driven region, the absorption of magnesium is an active process through the TRPM6 channel. So that's why when the DCT is affected by the Gentleman kind of a phenotype, there is an active magnesium wasting which has been found in these children. Whereas that is not the case which we find in the Barter's syndrome, where there is no active magnesium wasting. It is just a passive reabsorption which is getting affected. And as a result, the children are differentiated basically on the magnesium wasting. That means in Gentleman, you will have actual magnesium wasting, which is more severe as compared to those with Barter's. Whereas in Barter's, if you have the calcium wasting in Gentleman, by mechanism of proximal tubular reabsorption, the calcium will get absorbed, but not magnesium. And hence, because of this primary magnesium wasting, the magnesium levels are low in Barter's Gentleman's compared to Barter's. So that is a mechanism of the difference between the two.
Yeah, absolutely. Okay, second observation for the second case. This is from my side, one of the query. Like usually in the second case, I think it was a case of Gentleman syndrome, but proteinuria is not observed. We usually, So in your case, there was a +1 proteinuria present.
Yeah, so it was not quantified, but we found 1+. So maybe whether it should be repeated and quantification should be done.
Yeah, because there may be sometimes overlapping phenotypes also.
Yes,
with Barter.
So ideally, genetic testing would be the confirmatory, because many of these could have overlapping features.
Yeah. Okay. Thank you, Dr. Kiran. Next question is for Kamran sir. So, sir, one of the attendants there was, what is the normal value of urine electrolytes?
Normally, you would expect in the presence of you look at 20 milligrams per liter. Usually, that's the cutoff that is taken for urine, both for urine sodium and for potassium. So, but in the event of hyperkalemia developing, you would expect these values to go well above this. So it would be around somewhere around 30 to 40 milligrams per liter. In case you are finding values below 20 in presence of a hyperkalemia, you would expect that the renal secretion of potassium is less, and therefore you would have to explore those possibilities.
Yeah. True, sir. So obviously we can go for a more comprehensive test such as TTKG or fractional excretion of the potassium or fractional excretion of the sodium, as these values may be differ in cases of children. Especially we have a definite value for adult population, but for children, I think it's difficult to have cutoff values for the renal electrolytes. The next is a use of sodium bicarbonate in hyperkalemia, just if the child is acidotic. Is this right? So one of the delegate. So what? Hello.
Yes.
Yes, sir. So I think she want to ask that before use of sodium bicarbonate in hyperkalemia, just if the child is acidotic. Is this right?
No, in the presence of acidotic, it may be just acidosis. It may be justified. In the absence of acidosis, obviously you should avoid using soda bicarb as a means for reducing the serum potassium levels. If there is significant acidemia, you may be justified in using soda bicarb, but you must be sure that the patient is not hypervolemic. Most of the time, patient is hypovolemic.
Yes, sir. Thank you. Next question is for Kiran. In management of patients with hypokalemia, tubulopathies, what is the target for potassium? Do you want to be completely normal, or is as low normal level of 3 to 3.5 also is acceptable? And the second is, if this level is acceptable, do these patients have long-term renal injury from persistent hypokalemia?
Yeah. So depending on what is the cause of hypokalemia, one would try to change the potassium to the normal levels. But if it is like a significant pathology like a Barter's, where it's going to be a chronic hypokalemia because of the potassium wasting, then one would try to first eliminate these sources of potassium wasting or try to address the mechanism why potassium is being wasted by giving indomethacin and all those things. And ideally, one should try to achieve a normal potassium, because chronic hypokalemia, as we all know, is associated with a tubular damage itself. It can cause concentrating defect, and in the long term can cause cysts in the kidneys. So chronic hypokalemia should not be left unattended or unaddressed, and ideally one should try to normalize it as normal as possible.
Yeah. Thank you, Dr. Kiran and Dr. Kamran sir. And for this excellent talk, as well as for answering these all queries. Now I'll hand over this to organizers, Dr. Clevin.
Dr. Amrish?
Yeah, thank you so much, Dr. Girish, Dr. Kamran, and Dr. Kiran for such wonderful presentations. This was so enriching, and going over the potassium issues, I think it's always a learning experience. And each time we read about it, each time we go about it, I think we learn so much from it. So thank you so much for your excellent talks. And thank you so much, Dr. Girish, for moderating the session. Thank you all. I think, Dr. Clowney, do you want to say the last words?
I think you're all done.
Okay. Thank you so much
It was
again.
an excellent session.
Thank you.
Rangavelu sir, you have anything to add? Nammalvar sir, you have anything to add?
Sir.
Sir, you're muted.
Unmute,
Can
sir.
you
Unmute,
unmute?
sir.
Very comprehensive presentation by both the speakers. I really congratulate them. I think they must take a lot of time in preparing these topics. Thank them for this wonderful presentation. I think it's recorded, as Dr. Tangveli said last time. It will be great use for many of us who would like to go back and summarize. And when we want to talk to someone else, they can use it as a basic thing. Excellent presentation. And I think Kalaivan, you also planned everything and you got the right people for the right topics. Congratulations to you.
Thank you, sir.
Your boss, Dr. Tangaveli, is there to guide you. Thank you.
Thank you, sir. Thank you, sir.
Thank you so
Thank
much.
you, everyone. This
Time
concludes
for
the
dinner has
session.
come. Can I go?
Everyone. Thank
Yes,
you.
Yes.
Right, thank
yes,
you.
sir. Please, sir. Thanks, sir.
Yeah, thank you, sir. Thank you very much, sir. And thank you,
Kamran,
everyone, for
very
joining
good.
today.
You
This
presented
concludes the
nicely.
session.
Dr. Girish, Sunny's presentation was excellent. It was really wonderful to hear this from the same people. Thank you.
Thank you, sir. Thank you.
Yeah, this concludes our session now, and we will see you on Saturday, and we will be discussing cystinosis and idiopathic hypercalciuria. So please join on Saturday for the next session. Thank you, everyone.
Thank you.
Thank you.
Thank you, Dr. Girish.
Thank you. Yeah.
Thank you, Dr. Kiran. Thank you, sir.
Yeah.
Thank you.
Thank you.
Bye, Amrish.
Okay, see you. Bye-bye.
Bye-bye.